Welcome to your third set of notes in Unit 8, Clinical Psychology. We are going to be discussing personality disorders, which there are many of, and dissociative disorders. You need to make note that these are two separate categories within the DSM-5, but I'm going to cover them in the same set of notes. Before we can talk about dissociative disorder, you do need to note the definition of disassociation. And you need to think of it like daydreaming or getting lost in the moment while working on a project. We all experience this, and it is not a disorder until it becomes distressful or dysfunctional. This is characterized by separation of critical parts of the personality, like memory, consciousness, or identity, that are normally integrated and work together. And like I said, temporary dissociative states are common for most of us. When you're driving a common route to school or to the grocery store or to your friend's house, and you realize you don't recall going through an intersection, or if you even stopped at a stop sign, or if you're on a long road trip, you don't remember the last several miles. All of that is disassociation. You have kind of separated your consciousness from what you are doing, but it's not disordered. Now let's talk about the actual disorder, the dissociative identity disorder, oftentimes abbreviated DID, and it was once known as multiple personality disorder. Please keep in mind the definition we just went over for disassociation as we go through this, because you will see that connection. So this is a condition in which a person appears to have two or more distinct personalities, each of which can speak, act, and write in different ways. Different identities also seem to have their own memories, wishes, and impulses. Often the impulse of one identity conflict with those of other identities. And the problems occur because there is only one body available for the different personalities, forcing the personalities to take turns. And because there can be such strong variations in personalities, a person's behavior, when you look at them overall, can appear very inconsistent. This is a break in personality or a separation in personality, and from the outside, people will see huge fluctuations in their behaviors, which is a characteristic of DID. Herschel Walker is a former NFL running back. He talks extensively in his book called Breaking Free of his struggles with a dissociative identity disorder. He struggled to maintain close to a dozen personalities throughout his life, and they were very distinct. He had a personality that was the loving dad. He had a personality that was the tough football player. He had a personality that was the businessman, etc. They were very compartmentalized and very focused on a certain aspect of his life. Some famous cases of DID in the 1950s, there was the case of Chris Sizemore, and it was made into a movie called The Three Faces of Eve. 3 of Chris's 22 distinct personalities were depicted in the book and the movie and referred to by doctors as the meek and bland Eve White, the dominant and carefree Eve Black, and the mature intellectual Jane. Another famous case of DID is the case of Shirley Mason, also known as Sybil. In the early 1950s, Mason was a substitute teacher and a student at Columbia University. She had long suffered from blackouts and emotional breakdowns. The blackouts were because she was switching in from her personalities, from her different identities, and because of that and these blackouts, she did suffer emotional breakdowns from it, and just the distress of having the blackouts and not knowing what is occurring during those blackouts. She finally entered psychotherapy with Cornelia B. Wilbur, a Freudian psychiatrist, and their sessions together are the basis of the book called Sybil. Mason later moved to Lexington, Kentucky, where she taught art classes and ran an art gallery out of her home for many years. So she had those blackouts. Let me go back to this. And so it was like a period of unconsciousness. And that is the reason she sought out a Freudian psychiatrist, because she was dealing with things that were in her unconscious that she needed to address. And here is a list of some of the personalities of Sybil. You might want to pause and just kind of read through it so you can see the large variation in identities that she had within herself. She did have one that was a baby named Ruth, and then she also had two that were male. Now we're going to talk about the development of DID from the perspectives. So psychoanalytic is going to look at and discuss and focus on the massive repression of unwanted impulses or memories that create this new person who acts out otherwise unacceptable impulses or recalls otherwise unbearable memories. Something is causing memories or impulses to be pushed into the unconscious, and then the individual will create a new identity to either act out those memories and those impulses in, the unwanted behavior, or somehow deal with this. But it's the psychoanalytic perspective on how DID develops. Oftentimes with psychoanalytic, it's something has happened and the original identity cannot handle that trauma, and so they compartmentalize it. Behaviorist perspective is everyone is capable of acting in different ways in different situations. This disorder is the extreme variation of acting so different that you feel like a different person. Also, the symptoms are often strengthened by the reward that memory loss or shifting personalities allow an individual to escape stressful situations. With behaviorists, there is a conditioning, the associations, and there's been a conditioning of how to act within certain situations, and they just then over time develop. They just slide into these new kind of identities, put them in kind of quotes. Actually evaluating the true causes of DID has been difficult due to the rarity of the disorder. However, most clinicians believe that the root cause of this disorder is some sort of abuse or trauma during childhood. As I mentioned when we discussed psychoanalytic perspective, the child separated themselves from the abuse or trauma as a way to deal with the situation. And then they continue to do so throughout the rest of their lives because this is what they have learned on how to deal with stressful situations. And there are some who believe that DID is not an actual disorder, and they believe the individual may be a con artist or role playing to ease anxiety in his or her life. Now we're going to discuss personality disorders. So personality disorders, these are long-standing, inflexible personality traits that impair social function. So the unique characteristics that give a person their personality can become disordered. This is an impairment of the mind, but it's a part of who they are. So it's a disorder because it can be distressful, maybe not necessarily for the individual, but those around them, and it does cause dysfunction. So there are 3 clusters of personality disorder, and we will get into each different types that fall under each individual cluster. Cluster A is exhibit odd or eccentric behavior. Cluster B exhibit dramatic or emotional traits. Cluster C exhibits anxious or fearful behavior. Often seek treatment at the insistence of others, like a court order or pressure of a family member, as the individual is not distressed by his or her condition because it is a part of who they are. It's their unique characteristics. So to them, they're not being distressed by it. They're not in turmoil, but it is causing others to be distressed. And it is causing dysfunction in their life, regardless if they acknowledge it. All right, so under cluster A, this is the eccentric behavior. Paranoid is the first one we're going to talk about. This is characterized by paranoia and a pervasive, meaning they cannot get rid of it, long-standing suspiciousness and generalized mistrust of others. They are always looking over their shoulder. They are always thinking that others are out to get them. Schizoid is a pattern of indifference, as in not caring, to social relationships with a limited range of emotional expression and experience. The disorder manifests itself by early adulthood through social and emotional detachments that prevent people from having close relationships. These individuals do not have a wide range. They're kind of flat in their emotions. They don't have a lot of social relationships, and they easily break social relationships that they may have because they do not have an attachment with that other person because of their lack of emotions. And then you have the schizotypal. And this is a pattern of social and interpersonal difficulties that include a sense of discomfort. And this is how it is different from schizoid. Schizoid does not have a discomfort because of close relationships, but schizotypal does. So they have a discomfort with close relationship, eccentric behavior, and unusual thoughts and perceptions of reality. Patients usually experience distorted thinking. Oh, distorted. So here's the things that you need for a disorder, and behave strangely, and they avoid intimacy. Individuals that have schizotypal disorder they have a pattern of thinking that they have incorrect thinking of others and what others think of them. So now I want to talk a little more in depth about paranoid personality disorder. These are individuals with this disorder display pervasive distrust and suspiciousness. Common beliefs include the following: others are exploiting or deceiving the person. Friends and associates are untrustworthy. There's a lot of accusations from someone who is suffering from paranoid personality disorder. Information confided to others will be used maliciously. They accuse others when confidences are spilled. Okay, they share something about themselves with somebody else that they will then suspect and be very suspicious that other person's going to use it against them. There is hidden meaning in remarks or events others perceive as benign, which means like they are constantly thinking that if someone says something, they're like, what do they mean by that? What do they mean by that? Are they out to get me? And then, of course, the spouse and the partner is unfaithful. So all of these go back to that whole idea that they are perceiving that everyone is distrustful and everybody's behavior is suspicious. Now let's talk about cluster B, which is the dramatic emotional personality disorder area. There are 4 that you're going to have to know for cluster B. The first one is borderline, and this is marked by an ongoing pattern of varying or fluctuating moods, self-image, and behavior. The behavior for a borderline personality disorder is erratic. These symptoms often result in impulsive actions and problems in relationships. Histronic personality disorder. This is characterized by a pattern of excessive attention-seeking emotion, usually beginning in early adulthood, including inappropriately seductive behavior and an excessive need for approval. So when we talk about that inappropriately seductive behavior, we are talking about sex and being sexual in this personality disorder. The third one is narcissistic personality disorder. This is a long-term pattern of abnormal behavior characterized by exaggerated feelings of self-importance, excessive need for admiration, and a lack of empathy. Individuals who suffer from this personality disorder often are like, I don't care what you're going through right now. This moment is about me. Look how awful my life is. Or, oh my God, can you believe this thing, this event, this slight has happened to me? And it is always what is happening to them that is most important. Now, a little side note here when we talk about cluster B, because these are the emotional, these are the dramatic personality disorders, and you may be looking at this going, I do not want to be friends with anybody who has one of these disorders. And that is an honest and an okay feeling to have, because being friends with someone who has these disorders would be very difficult, but they are human, and we need to understand that they're suffering. And because of their suffering, we don't need to be judging or being judgy and encourage them to seek treatment so that they cannot have a dysfunctional and distressing life. Now let's talk a little more in detail about borderline personality disorder. This is a pervasive pattern of unstable and intense interpersonal relationships, self-perception, and mood. Impulse control is markedly impaired. Okay, this is a cluster B, so emotional, dramatic. This is why it would be cluster B. Diagnostic criteria require at least 5 of the following features, meaning an individual to be diagnosed with borderline personality disorder, they have to have at least 5 of the following: frantic efforts to avoid expected abandonment, unstable and intense interpersonal relationships, markedly and persistently unstable self-image, impulsivity in at least 2 areas that are potentially self-damaging, recurrent societal behaviors or threats or self-mutilation, effectively instability, so their emotions are unstable, chronic feelings of emptiness, inappropriate and intense anger, and transient paranoia or disassociation. Recall the definition from disassociation earlier in these notes. Oftentimes, a way for a person who is suffering from borderline personality disorder, they will try to self-cope through substance abuse. They will also, sometimes you will see coping skills being promiscuous or very sexually active. And of course, that inappropriate and that intense anger coming out in very odd situations. The 4th personality disorder in cluster B is antisocial personality disorder. It is the most well-known personality disorder. I do need to kind of go over what the definition of antisocial means. We will discuss antisocial in the social psychology unit, which is unit 9. But antisocial is a negative effect on society, or it is behavior that is not acceptable by society. And it can have a negative effect on other people, on the individual themselves, or society at large. Now, there's another term called prosocial. That's like altruistic. This is a positive influence on society. These are positive influences on other individuals. And when you think antisocial, don't think that they should not be in society. Okay, that's not antisocial. Ooh, they should not be in society. No, it is what their behavior is doing is not accepted by society. Clinical features of APD, they must include at least 3 of the following. They lack of conforming to laws, as evidenced by repeatedly committing crimes. They repeatedly commit crimes, and if you think about what the definition of antisocial, that makes sense. They are doing something that has a negative effect on society. Repeated deceitfulness in relationships with others, such as lying, using false names, or conning others for profit or pleasure, i.e. con artist. An antisocial personality disorder can be very charming. There's a failure to think or plan ahead. There's a lot of impulsivity with this disorder. The tendency to irritability, anger, and aggression, as shown by repeatedly assaulting others or getting into frequent physical fights. And there's a disregard for personal safety or the safety of others. Again, a negative effect on society. So if it's risky, they're more likely wanting to do it. This disorder cannot be diagnosed until an individual is 18 years old, but to be diagnosed with APD, the individual must have shown symptoms of the diagnosis since 15 years of age. Usually the individual has been previously diagnosed in childhood with a conduct disorder, and that is coming up. I'm getting ready to talk about that. It is actually covered in a different set of notes in depth, but I will kind of briefly cover it in these. Occurs more often in males than females, and sometimes we'll see the terms sociopath or psychopath in relation to APD. They can be very charming. They can be very convincing, and they lie very easily. And they will lure people in, which then leads to a more destruction in the people's lives that they are, having this negative effect on. Causes of APD. Some studies have suggested a genetic predisposition, possibly in the form of chronic underarousal of both the autonomic and central nervous systems, which leads to abnormally low anxiousness, which may make people less sensitive to punishment. And other research has linked an underdeveloped amygdala to APD. Others believe that environmental factors like broken homes, rejection by parents, poor discipline, lack of good parental models, lack of attachment to early caregivers, impulsivity, conflict-filled childhoods, and poverty play a role in the behavior exhibited by antisocial individuals. So understanding APD, these are PET scans of 41 murderers revealed reduced activity in the frontal lobes. In a follow-up study, repeat offenders had 11% less frontal lobe compared to normal brains. So earlier I mentioned that they would have to be diagnosed with a conduct disorder to then get the antisocial personality disorder at 18. We will talk about conduct disorder in the neurodevelopment disorder notes because that's actually how it's classified in the DSM-5. Because these occur in children, they are not and cannot be considered personality disorders. They don't consider personality disorders until 18. So conduct disorder is a repetitive and persistent pattern of behavior in which the basic right of others or major age-appropriate norms are violated. These behaviors are often referred to as antisocial behaviors, and those antisocial behaviors then turn into antisocial personality. And then oppositional defiant disorder. This is a frequent and persistent pattern of anger, irritability, arguing, defiance, or vindictiveness towards parents and other authority figures. So in conduct disorder, the antisocial behaviors are much more intense on what they are doing wrong, on the bad behaviors. Oppositional defiant disorder is not as bad or as intense as conduct disorder. This is more about emotion versus conduct disorder is about behavior. And our last set of personality disorders, cluster C, this is the anxious cluster. These are kind of self-explanatory, but I will go through them very quickly. Avoidant. This is characterized by feelings of extreme social inhibition, inadequacy, and sensitivity to negative criticism and rejection, causing significant inabilities to maintain relationships in day-to-day life. They are not able to socially interact. Essentially on avoidance. They just cannot socially interact. Dependent. Characterized by an inability to be alone, developing symptoms of anxiety when they're not around others, and needing constant reassurance from others to function. And then obsessive compulsive personality disorder. So we've talked about obsessive compulsive disorder. There is an obsessive compulsive personality disorder. So this is characterized by a preoccupation with orderliness, perfectionism, and mental and interpersonal control at the expense of flexibility, openness, and efficiency. So OCPD is not about intrusive thoughts. So OCD is about intrusive thoughts that then cause them to do a ritual to relieve that, to get rid of that intrusive thought for a while. But OCPD is not about intrusive thoughts. It's a preoccupation with who they are. It's a preoccupation that is a part of it's a part of them. It's who they are. They are all about order. They are all about doing things the same way each time. So obsessive compulsive, in this case, it's the personality. It is their unique characteristics. Okay, so that wraps up this third set of notes, dissociative and personality categories for Unit 8 Clinical Psychology. If you have any questions, let me know. And don't do anything too stupid. Bye, guys.